Today we're going to talk about a new topic. This is a hot off the presses lecture, so none of you have seen it before if you tune into Louisville lectures. We're going to talk about hypertensive crisis, and I'm purposely calling it hypertensive crisis, and we're going to see why in a second. So you've heard of these terms before: hypertensive urgency, hypertensive emergency, malignant hypertension. Who wants to take a stab and define hypertensive urgency for me? Or emergency? End organ damage. Okay, but what do you guys learn? You're reluctant to say because I named this hypertensive crisis instead of urgency or emergency. So tell me, what have you learned as the definition of hypertensive urgency? Does anyone have a number that they've learned?
Systolic greater than 180.
Okay, so people throw out numbers. Systolic greater than 180, maybe diastolic greater than 110. You've heard these things before, but it turns out that none of those mean anything at all. So I actually don't use any of these terms whatsoever. I don't use urgency. I don't use emergency. Malignant hypertension is an old school term that's only used for coding purposes, so we don't really use that term either. So instead, I think there's only two things: hypertension, just hypertension, and hypertensive crisis. That's the only two flavors in my mind that things come in, right? So hypertension is just elevated blood pressure. Hypertensive crisis for me is severely elevated blood pressure with end organ damage. So I guess if you want to use emergency in your mind, but for me I call it hypertensive crisis, because crisis indicates I got to do something about it now. And I don't like those old terms because they don't mean anything at all. What does hypertensive urgency mean? What did that communicate to you that you were supposed to do about hypertensive urgency? Right. Do you put him in the hospital? Do you put him in the ICU? Do you just give him an oral medication? So for me, I only think about, is there end organ damage or not? And specifically, there has to be acute end organ damage to constitute a crisis, as opposed to the chronic end organ damage that happens from chronically elevated blood pressure. So this is the way, in my mind, I think about it. I want to strike from the record and strike from your lexicon hypertensive urgency or emergency. So if you round with me, you're going to tell me it's hypertensive crisis or just run-of-the-mill hypertension. That's the only two things that there are. Okay, so what are some examples of end organ damage, acute end organ damage from hypertensive crisis? Shout it out, I've got candy. Oh, and on top of telling me what the end organ damage is, you have to tell me what test you would get to evaluate for that.
Altered mental status.
And what kind of test? Okay, so altered mental status. So neurologically, let's stick on brain. What else brain-wise can happen?
Stroke.
Okay, stroke. And what are you going to get to test for stroke? Okay, CT head. I don't know who said that. Probably not Nelson, but whatever. Okay. Actually, on some of the Louisville lectures comments, they were like, who's Nelson and why does he answer all the questions? So whichever of your listeners was that, and Nelson didn't answer that question. Okay. So stroke, and you're going to get a CT head. What else are you going to look for in CT head that can happen? Bleed. Who said that? I don't know. Candy goes out. Nelson, dang it. Okay. What else neurologically? So we have altered mental status, we have stroke, we have intracranial hemorrhage.
Vision change.
Good, vision change. Can you be more specific about how the vision change? There are a couple of mechanisms. Okay, so retinal hemorrhage is one. That was for behind you. And this is for you. Sorry. Oh, for the record, I did hit someone in the eye. I told you, sorry, to wear protective eyewear. That's why you can't check your email during my lectures. Wow. I'm sorry. Can you still see? Do you have a retinal hemorrhage? Okay, so retinal flame hemorrhages in the retina. What else can cause loss of vision? Yeah, go ahead.
Press.
Good, press. Yes, we have a case coming up. Oh, man. I don't know if I can get this all the way back there. Not at all. Okay. Press. So posterior reversible encephalopathy syndrome, which is basically edema in the occipital lobe. That can cause loss of vision. And then I can think of one other thing in the eye. Okay, so I'll take carotid dissection from aortic dissection, compromising retinal flow. That'd be a stretch. It's possible, but that could happen.
Ruptured in the ophthalmic artery.
Okay, so ophthalmic artery, acute stroke and ophthalmic artery, usually not hypertension related, but it is something that I would see when I look at the fundus. How about papilledema, right, from elevated intracranial pressure? Okay, good. So that's our neurologic stuff. Actually, no, there's one more neurologically. How about if it was a pregnant person with hypertension? What neurologically can happen? Seizures, good. So eclampsia, right? That would be eclampsia. Okay. What other end organ damage might we have? I didn't hear whatever someone said. Okay, good. AKI, acute kidney injury. That can be hard to tell the difference if we don't know the baseline. What else? Renal, since we're on renal. What did I hear? Did I hear scleroderma? Oh, nice. That's coming up later. Scleroderma renal crisis, absolutely. Woo, nice catch, kind of. We'll get to scleroderma renal crisis. How about in someone who doesn't have scleroderma? So we said acute kidney injury. What else do you look for when you send that urinalysis? Hematuria, good. So reds in the urine or red cell casts. And then also proteinuria. Again, that can be difficult to differentiate between acute versus chronic hypertensive damage. Okay, so moving on from kidneys, what other organ could be damaged?
What about the heart?
The best organ. What could happen to the heart?
We get myocardial ischemia.
Absolutely. So we could get, I'm not giving you candy because I've already given you like 4 so far. So we could get subendocardial ischemia from wall tension from severely elevated afterload. So that, and it can look for all the world like a plaque rupture MI, but we're always trying to figure out, is this a subendocardial ischemia from decreased perfusion? Absolutely. What else? Some sort of heart/vascular. We kind of already touched on it. Good, dissection. Actually, I will give you one, Chris, because you said dissection earlier too. Aortic dissection, aortic dissection. So we're going to talk all about aortic dissection. That's really crucial. What tests are you going to get to look for aortic dissection? CTA. What if they have a creatinine of 2.5?
Don't care. Do it.
Okay, so don't care. What if they... That's possible. What if they have an IV contrast allergy?
CTE, prednisone, premedication.
Yeah, so pre-medication, they have true anaphylaxis, so you don't want to pre-medicate and stick them in the scanner.
We got an on MR.
Good. So MRA actually can work. And that can be tricky depending on what the renal failure is like, but it should be MRA with contrast is the best way. You can sometimes see the wall without contrast. And then finally, if you're really stuck and they're 700 pounds and can't fit in the MRI, and they have anaphylaxis to contrast, TEE, that's exactly right. And thankfully at this institution, you can get Dr. Stoddard or colleagues to come in and do a TE at any time of the day or night. So you're a little spoiled. Don't expect that you're going to get that everywhere that you go. So good. Those are the ways to look for aortic dissection. Okay, what other organ? Because we're going to stay here all day till we get all of these.
Lungs.
Good. Lungs, what happens in the lungs? Pulmonary edema. Great. Chest x-ray will tell us that. Okay. What else? How about some interns? Are there any interns here? So we did lungs, heart, brain, kidneys. Anything else that we're missing? We already talked about pregnant women with eclampsia, preeclampsia. Anything else you could think of? That's pretty good. Intestinal ischemia would be pretty rare to get from hypertension. Here we go. Okay. Fabulous. Okay, I think we got pretty much everything. So keep all of these things in mind. This is, as you know, this is a challenge to differentiate between the acute and the chronic stage, but you really have to try and understand, is this an acute change? Because that's going to completely change your management. So here's just a little scheme. We're mostly thinking about brain, heart, kidneys are the most obvious places that this manifests, but keep in mind all of your other possibilities. Okay, the pathophysiology of hypertensive crisis is not known. This is a guess, but we really don't fully understand what happens. So we think that for some reason, this is tricky, you get increase in circulating vasoconstrictors. What causes that increase in circulating vasoconstrictors? We don't really understand what the stimulus is, but we think that that happens first. Then when you get vasoconstriction, you can end up with endothelial damage. And remember, anytime that we disrupt the integrity of the endothelium, then we can actually activate coagulation cascade, fibrin, clotting. So now we have, in addition to vasoconstriction, now we also have localized activation of coagulation cascade. All of that's going to lead to ischemia at the tissue bed. Then, when you get ischemic, that only exacerbates things because ischemic tissue, remember that it will cause further increase in the local vasoconstrictors because now your endothelium is damaged, so you're going to respond with vasoconstriction. Then you get volume depletion, activation of your renin-angiotensin system, and that all leads to end-organ hypoperfusion, both from the vasoconstriction and from the activation of the clotting cascade. And then this ends up being sort of a vicious cycle. So this is what we think. Nobody really knows. This is our best guess about the pathophysiology. What we do know about is autoregulation. So has everybody seen this curve before? You should have this curve memorized. This happens in many of the vascular beds in the body, but the cerebral vascular bed is the one that's most well known. And this is part of how we dictate our treatment for hypertensive crisis. So this yellow line is people who are normotensive. And what you know is that over a large range of mean arterial pressures, from as low as 50 to as high as 150, the brain's vascular bed is able to auto-regulate the flow and keep the cerebral blood flow constant between those large range of maps. And that's because you can't have huge fluctuations within the enclosed skull. But remember that when people become chronically hypertensive, over time, that's going to shift the curve to the right. So this orange curve is showing you that in someone who lives with high blood pressure, that map over which they maintain their cerebral blood flow is severely shifted. So now we're going from something like 90 to 170. So if I drop my map all of a sudden back to normal in someone who has chronic hypertension, they're going to not perfuse their brain. Has anyone, well, maybe I won't make you show of hands, I'll tell you, I've done this before, or those under my supervision have done this before, where we accidentally drop their blood pressure too low, they get altered mental status, they start to have stroke-like symptoms. That's a bad day at the office. So this graph is why we're so cautious about how and to what extent we lower the mean arterial pressure. So our treatment approach to someone who has hypertensive crisis is relatively simple in theory. It gets more complicated when you try to figure out the details. So the first thing is, if they just have chronic hypertension, you just lower it over the course of weeks in clinic. And you all know this. Someone who comes in first visit, their blood pressure is 170. Okay, if you want to weight the 3 different measurements, whatever, but you know they have hypertension. So you start them on maybe 1 or maybe at most 2 meds, but you're not trying to get them down to 120 right away. So we're not going to talk about chronic hypertension, but you guys treat that all the time. Now, I'm going to throw in something, quote, severe hypertension. This is that hypertension that just makes you feel uncomfortable. So this is when someone comes into your clinic with a blood pressure of 220, and you feel like you should do something about that possibly. But they're feeling fine, right? Hypertension is the, quote, silent killer. So they didn't even know that their blood pressure was this high. So what do you guys do for that person? You send them to the hospital for a blood pressure of 220 with no symptoms whatsoever? Recheck it, that's great. Maybe they walked in, they were a little bit stressed from walking in. Okay, recheck it. It's still 195 systolic. So what we used to do is pop the nifedipine in and then wait 30 minutes, recheck the pressure, it was 160, have a nice day. So usually you just need to get them back on their meds because they didn't take them that morning, or you up-titrate something. But it feels bad on the inside to let someone have a blood pressure of 220 and not race them to the hospital. But again, this is where understanding that if there's no end organ damage, it's actually worse if I try to rapidly lower that blood pressure than if I just give them something oral and get them onto medications. And then hypertensive crisis, again, where we have end organ damage. So this is the classic what you're taught. Lower the mean arterial pressure 10% in the first hour, and then a total of about 20 to 25% over that maybe first 4 hours. You kind of try to leave it there, slowly lower it over the course of the rest of that 24 hours, and then slowly over the course of days get them back down to maybe normotension. Maybe you won't be able to get them all the way down to that. It's important to know, are there any randomized clinical trials teaching us this? Not at all. And how would you even do that trial, right? So this is all theory. And so we're doing our best that we can for the individual patient, but that's the whole idea. Usually you're going to need to use IV medications because you need to get things down quickly. And so they should be in an ICU if this is really hypertensive crisis. Now, please don't go putting patients in the ICU for hypertension. If you're just treating them with oral medications, probably don't need to be in the ICU. And I see this happen all the time, right? There's a one-time reading on the floor of 200, everybody freaks out, they insist that they come in the ICU, and then you're like, all I'm doing is giving them amlodipine. So you try to be judicious about this and really differentiate between the people, I've got to rock and roll, I've got to get this blood pressure down, and those that I can do this slowly over the course of the next day. So the way that I choose my treatment is the following. First, I'm going to calculate what's your map right now and what's my target map, so I know what I'm aiming for. And I use maps, not systolics, in these patients, unless they have something like, if they have a really huge wide pulse pressure, so that's making my map look lower than my systolic. Well, first of all, what are you going to be concerned about if they have a really wide pulse pressure?
Aortic.
Yeah, I'm worried about aortic dissection causing aortic insufficiency, in fact, so that's going to make me concerned. But I might use systolic in that case, but most of the time I'm going to use their map, calculate my current map and my target map. They need IV access and they need an art line. If you are treating someone with IV medications for their blood pressure, they need an arterial line, right? You can't rely on the every 4-hour blood pressure cuff, and you really want accurate measurements. So if you're going to do this, be parsimonious and put in that arterial line. Then I choose an agent, and this is where things get complicated, right? So how do you choose what agent you want for this? Well, I kind of go in a couple of different steps. So the first thing I think is, are there anything that are contraindicated in this particular patient? So I'm thinking about heart failure and beta blockers. I'm thinking about low systolic function and calcium channel blockers. I'm thinking about renal failure and ACE inhibitors. So I'm figuring out, is there anything that's contraindicated which I can't use? That's first step, eliminate options. Then I'm trying to think, is there anything that would be particularly beneficial for this patient and their presentation? Like something special like eclampsia or aortic dissection. And then I'm going to choose those agents. And then the last thing I think about is, how long does my IV medication last, and how easy is it going to be for me to transition to oral? Because it's one thing when you're the on-call resident to be like, as we discussed, put him on a nitro drip, blood pressure got better, have a nice day, 8 a.m., good luck, guys. But I'm trying to think about what's going to happen 24, 48 hours from now when I need to transition them, and how difficult is that going to be? So I'm always trying to choose something that is easy to transition to PO, and if possible has a relatively short half-life, or at least I'm aware of the half-life so I can be appropriate when I overlap things. And then you really can't forget to do a secondary cause workup. I'm not going to cover that in this lecture today because it's a whole separate topic, but you should automatically be thinking about, are there secondary causes of hypertension in this person, and what is appropriate to evaluate for in the hospital and what is not. We'll cover a few of those sort of special cases here, but that should be in the back of your mind. So your treatment of that patient is not complete just with all of the above, IV access, starting them on an agent, getting their map down by the morning. You also should be talking to me on rounds about what are some reasonable thoughts for a secondary cause workup, and what should we do now versus wait till the outpatient world. Okay, woo, this is a busy chart that I made just for you. You're welcome. I made this on my own. Okay, aren't you proud of me? I should give myself candy. To me, these are the only drugs that I think about when I think about treating hypertensive crisis. So we are going to go through these one by one. This is a little bit dry, but it's really important. These are the things I'm thinking about when I'm looking at medications. So we start with nitroprusside, my favorite drug. This is the best medication. It costs, beware, about $35,000 a day because some jerk took the generic and then rebranded it. You know how that's been happening lately. So it's very expensive, but it is really a great medication. It is a almost pure arterial vasodilator. It might give you a little bit of venous dilation, but it is primarily, first and foremost, an arterial vasodilator. So this gives me pure afterload reduction. Its onset is immediate, and it lasts for about 3 minutes. So if I guess wrong and I turn it off, it's gone out of the system. That's part of why I love it so much. You start at this dose, 0.3 mics per kilo per minute, and you titrate to effect. Now, I will personally say that when I'm using nitroprusside, I'm often using it for afterload reduction in patients with systolic heart failure and cardiogenic shock. So they're not as hypertensive. In that situation, I don't allow nursing to titrate, I self-titrate because I actually come and maybe every 30 minutes I make a change. In the person who's actually frankly hypertensive, you can have nurses titrate, but beware, you don't want to go cranking super fast. You want to give a little, even though the onset is immediate and the half-life is short, I try to be a little bit judicious about how I do this, so maybe circling back every 15 minutes or so and seeing what the blood pressure looks like and titrating it. There is no oral version of nitroprusside, so usually we end up going from nitroprusside to hydralazine. That's usually the transition that we do. The things you have to worry about: thiocyanate toxicity with prolonged use. They feel nasty, nausea, vomiting, they get all twitchy. You can send a thiocyanate level, but that takes a little while to come back. Can also get cyanide toxicity and methemoglobinemia, very, very rare, so I'm not really touching on it. And then you have to be careful in renal failure because this is renally cleared. That doesn't mean you can't use it in renal failure. It doesn't cause worsened renal failure, but it sticks around longer. So if I have someone who has a creatinine of 2.5 and I'm using nitroprusside, I'm going to be even slower about my titration, and I'm going to also try to get it off faster because the longer that you have it on, the more the toxic metabolites accumulate. So that's nitroprusside, the best drug. If you start throwing this on everybody, though, you're going to get a call from the hospital because it's so expensive. So I use this primarily when I can't use something else. Okay, nitroglycerin we kind of talked about. This is really almost pure venous dilation. It does have the added benefit of giving us coronary artery vasodilatation. So this is a great medication for the subendocardial ischemia patient that you think has fixed coronary disease and is hypertensive. This is going to get us bang for our buck. So it's immediate onset of action and it lasts for 5 to 10 minutes. I want to harp on this for a second. If you've rounded with me, you've heard me say it. The starting dose is about 10 mics per minute. You don't dose it based on weight. 5 or 10 mics per minute you can start. When you give someone a sublingual nitro, how much is in that? 0.4 milligrams. So that's 400 mics. So this is much less potent than a sublingual. So if you're worried about blood pressure, and for whatever reason, this is a great thing to use. And it also will last longer than what the sublingual is. So the problem here is tachyphylaxis, right? So you've all seen this happen. They pull nitroglycerin in the ER because that's what they have. It's easy, it's quick, it tends to work immediately. Then they're like, great, blood pressure's controlled. You bring them up to the ICU, 4 hours later, blood pressure's back to where it was. And that's because the body actually tachyphylaxis. That means it becomes accustomed to the nitroglycerin. So you end up having them on 150 mics of nitroglycerin by the time I come in the next morning. I don't know why it's not working. So I think, to answer the question that Drew you had asked earlier, I like nitro for the immediate. I need to get the blood pressure down right now. And I used to argue with the ER in my younger, more wily days. You're like, why are you starting nitroglycerin? That's not going to work. Then I realized that's what they have. It's there. It's easy. It's cheap. Great. So start them on the nitro, and then it's my job to transition them when they come upstairs. And then also headache, as you know, a lot of people get headaches from the nitro. Okay, moving on to some others. Nicardipine or Cardine, you've heard. It's a calcium channel blocker. Pretty quick onset of action, 5 minutes, but this thing lasts a long time. So the thing here is that you can transition it directly to another calcium channel blocker, so that's nice. But when you do that, your overlap has to be pretty prolonged. So this is going to last me for 6 hours. So what I usually do is, because my oral calcium channel blocker is going to take several hours to kick in, I will say, let's say if I want to go from nicardipine to nifedipine. You guys don't use that much, but I did in residency. So I might give 30 milligrams of nifedipine now, turn off my nicardipine drip, and by the time that my nifedipine has kicked in, my nicardipine drip has probably come off because they're about the same. So that's the way in which I overlap those two, but I'm being very, very cautious in my mind to recognize that if I chose the wrong dose of the nifedipine, I may have to give an extra dose, 8 hours from now when the blood pressure goes back up. So this one is a little bit tricky because of the long half-life, and you've got to be careful in heart failure. Now, technically, this shouldn't have the same negative inotropic effect that something like diltiazem or verapamil would have, but I am distrustful of any calcium channel blocker in bad systolic heart failure. So if someone has an EF of 10%, I stay away from all the calcium channel blockers unless I have absolutely no other options. But guess what? I always have this option. So I really don't like calcium channel blockers in systolic heart failure. Labetalol is a great drug, right? Alpha-1 and beta blocker, quick onset, but a relatively long half-life, about 5 hours. You start with a bolus, and then you titrate it up. You can convert it to PO directly, which is awesome. Again, you have to kind of do the same thing where you overlap them, turn off the drip around the same time as I give the oral, maybe overlap by an hour there, and then see if I guess the right dose. But of course, you have to be concerned about heart block, bradycardia, and then if they have systolic heart failure, you really don't want to be giving them this beta blocker. Okay, hydralazine, you know about this. This is a direct vasodilator. Quick onset of action IV. Lasts for about 4 hours. You've seen this, right? You guys have all used hydralazine IV PRN. It starts wearing off right after that 4 hours. So when you have it Q8, then they're always hypertensive again 6 hours later. So this is really a Band-Aid or a little bit of a bridge if you just have no other options and you're really trying to get the blood pressure controlled for the sake of something else and you can't yet put them onto oral. So stroke patients, you'll see a lot of PRN hydralazine there. There's a reflex tachycardia that can tend to happen. So the classic teaching is you shouldn't give hydralazine to someone having an MI because you might lower the blood pressure, but you're going to increase the heart rate. Sometimes I see this, sometimes I don't. So I don't use that as a very strong negative or as a very strong telling me not to use hydralazine, but just be aware of it. And then finally, this is not an IV medication, but I put Captopril on here because I love it. You guys don't use a ton of it, but I usually make you when you're on service with me. Enalapril is in parentheses. It's an IV ACE inhibitor that was studied initially in the setting of acute MI. I don't tend to use a lot of enalapril, but if they can tolerate PO, what I love about Captopril is that it's a relatively quick onset of action and It also lasts me for that 6 hours. So I can titrate this over the course of 24 hours. I give you 6.25 of captopril. If an hour later your blood pressure is still high, I give you another 6.25. Then 8 hours or 7 hours now from now, at the next time point, I give you 12.5. So I can actually double you every 8 hours and get to a high dose. That's, to me, better than choosing lisinopril 10, see if it works. And then this is really easy to convert captopril over to lisinopril. So this is a good thing to get experience with. Of course, you have to be careful in renal failure and bilateral renal artery stenosis. Okay, so that was a lot, but this chart for me, this is how I think about these medications when I'm choosing. Any questions on particular agents before we do some scenarios?
Do you dialyze nephron?
That is a good question. I don't know off the top of my head if you can or not. Usually you just turn it off, and because it has that relatively short half-life, it will get out of the system. And if they have renal failure, it might take a little bit longer than it would in someone without, but usually just turn it off and switch agents.
How much of a drop is it reasonable to expect with one dose of IV hydralazine? Because that's the other fear, right? Like dropping too much.
Yeah. That's part of the difficulty, is that you can't control, and you don't know what someone's going to do to the hydral, and once you've given it, you can't turn it off. That's the same concern that you have with something like nicardipine or labetalol, is that it has a long half-life. So that's why nitroglycerin is reasonable to start with, and then you kind of see how did they respond, how labile are they, and then transition over to a low dose of something else that's longer acting. So there's a lot of art to this. Yes?
Did you get any myocardial vessel dilation with the nipride?
You do not. It's just pure afterload reduction, so it does not give you any selective coronary artery vasodilatation. Great question. Yes?
How much should we know about phenoldiazepam or clobazam? Are they using it?
I'm going to show you the only things I know about it in a few seconds. Great question. We're going to get to Theo. Yes? Oh, I'm sorry. Hold on. Go back. Phenoldiazepam. I heard phenoxybenzamine. I don't use phenoldiazepam. People are using that now because it's cheaper, and when nitroprusside got expensive, they started using it. But for my patient population, because there is still concern about negative inotropy because of calcium channel blocker, I'm tending to stay away from phenoldiazepam. So usually I think you're going to have another option here, but it's reasonable to get some experience with it. I don't have much experience with it at all. Okay, yes, back to you. So esmolol, in theory, should not really drop your blood pressure. It should be used more for tachycardia. And you can even use that, right, for an SVT in the setting of sepsis, because it should give you primarily heart rate control and really shouldn't do much in terms of the blood vessels. But every once in a while, you're going to see someone drop the blood pressure. It's not on my list of treatment for hypertensive crisis. It's on my list of treatment for SVT. Yes?
Do you worry too much about tachycardia with nipride?
I don't worry about tachycardia with nitroprusside. Good. Any other questions? Okay. And caveat, this is my way of thinking about this, so there might be other considerations, but I think I have a fairly nuanced way of thinking about them.
Do you have another question?
Yeah.
If you have trouble controlling the pressure on pretty much a max dose, what would be your go-to second?
Good. So the question is, if we can't control, if you've maxed out on one agent and you're still not controlling, and what second agent do you go to? So then I'm gonna look at all my parameters. I'm gonna look at my heart rate. So can I add in a beta blocker now? I'm gonna look at, can I add an oral medication on top of my IV medication that I'm gonna get some nice, more even control because I've got the blood pressure reasonably down. I personally don't like to mix calcium channel blockers and beta blockers. I don't like to give things that both act on AV node, even if the calcium channel blocker shouldn't totally act on the AV node. I don't like to mix those two because of relatively similar mechanisms of action. So I'll try to choose something a little bit different. But by the time I'm maxed on one, I'm trying to think, can I add in, or hydralazine PRN can be a nice, again, little bridge in that situation. But by that time, I should be trying to think about, can I get them onto something oral?
If you have somebody who comes in and you think they have normal kidneys, but they obviously have a protein and an API, would you consider giving an ACE to reduce that glomerular pressure to kind of be protected?
So the question is, in someone who has previously normal kidneys that we think has AKI and proteinuria from hypertensive crisis, would I consider an ACE inhibitor? Only in one situation, which I'll get to in a second. I usually don't give ACE inhibitors if there's a strong component of AKI. Okay, so let's talk about a few special circumstances. So first, aortic dissection. So this pathophysiology is well known. You tear the intima, right, the innermost layer of the aorta. Then that causes the degeneration of the media, the middle layer, if it's non-traumatic. Then blood goes from the lumen into the media and just dissects down the middle of that plane, and that creates a false lumen, and sometimes the false lumen is even going to be bigger than the regular lumen, and then the propagation of the dissection can go in either direction. And these actually tend to spiral around the aorta, which is kind of cool. They can also have multiple re-entry sites back into the lumen. So this is an old schematic of it, but essentially you can see here you have this tear in the intima, and then it goes into the media, and then this is just like knife cutting through butter, that the blood dissects through that media. So there's different types, but first I want to explain something. So the reason why we want to control blood pressure and heart rate so aggressively is because imagine that with every beat of the heart, right, you're just tearing further and further and further and further. Okay, and that's sure, and death. So there's different types of aortic dissection. This matters not just to make you look smart on rounds, but because our treatment is different. So type A is going to be ascending. You only need to know these types. You don't worry about DeBakey classification anymore. So if you have a type A aortic dissection, that means it involves the ascending aorta. That doesn't mean that the dissection itself ascends. The dissection actually usually propagates backwards towards the heart. And it usually starts in the right lateral wall of the ascending aorta. So what can be bad about a type A? What can happen? What can get involved?
Valve.
So yes, you can get down to the aortic valve and cause acute aortic regurgitation. What else? So the head and neck vessels, right? Because they're going to take off of the arch, so you can dissect the head and neck vessels and get strokes. And the right coronary artery. Oh yeah, music to my ears. I have actually seen this happen, sent someone for emergency surgery at like 2 a.m. because they were there with their aortic dissection. We had everything under control in the ICU, then all of a sudden chest pain, EKG, terrible looking global ischemia, ST depressions everywhere. The dissection was propagating into the ostium of the RCA. That person's got to go immediately, get those arteries taken out, plugged into the new graft. Ooh, where did it go? Okay. Type B just means it's in the descending beyond the ligamentum arteriosum. And here's some schemata. So the DeBakey classification we've really gone away from. Really, we just use type A and type B. And that's because that differentiation of the ascending aorta versus the descending is really all that matters in terms of management. So how does this present? You all know this, but just humor me. How does the aortic dissection present?
Like that.
I want to throw candy to someone. Chest pain. I want you guys to get some candy back there. Oh, I'm not going to try to overhand it. Watch out, people. Okay. So abrupt onset of your chest pain radiating through to the back. Unequal bilateral blood pressures. This is not an adequate way to rule this out. Sometimes we do that when I really don't want to scan them. But I'm going to combine that with what serum test can you get? So the D-dimer is actually a really good negative predictive value for this. So if I have even bilateral blood pressures, a chest x-ray without a wide mediastinum, and a negative D-dimer, and my suspicion was low, I'm okay. But if my suspicion is medium or high, you just got to get imaging. And we already talked about how we get that imaging. So this is some interesting information. Here's a picture of a widened mediastinum. Please nobody ever tell me that that's pulmonary vascular congestion. Because if you do, I'll dissect your aorta. This is interesting, though, because in type A, the mediastinum is widened about 63%, and in type B, about 56%. So this in and of itself is not a very good test. If you see it, though, you've got to act on it. And you notice that this is not a squished film. The rib spaces are wide. This is not because they didn't take a good inspiratory effort. All the things that we usually say to tell ourselves we don't have to look for a dissection. Here's just a cross-section on the CT scan. So you can see here's my right ventricle. And the contrast is here in the aorta. And I have this beautiful dissection flap right through the center of that. And here is what's nice about CT scan. So I told you that this spirals. So this is some awesome cuts where you can actually see that the dissection starts up here and then it spirals around the aorta. And then here's a 3D reconstruction. So it really dissects kind of in this spiraling fashion that you see. And then depending upon what's on the true versus the false lumen, this is going to change our surgical management. Okay, so transthoracic, every once in a while you get really lucky and transthoracic is going to pick this up. So here's my left ventricle, left atrium, mitral valve, aortic valve. This is my aorta right here. My right ventricle is up here. What is this? False lumen, yeah? So here I actually have, it's not flapping around, but this is my dissection right here. So here we got really lucky and picked this up. I've seen this on a routine outpatient echo pick up a type A dissection, which is a a bad day for that patient. Here's the color that's flowing across it. So you can actually see there's a little bit of aortic regurgitation, but you can actually see color going up into this area in the lumen. That's one of the ways we determine if there's blood flow. But can everyone see that? There's a little flame of color going right through that spot right there. Here's another transthoracic echo. Oh my gosh, this one makes my heart skip a beat. Okay, so left ventricle, right ventricle. This is the apical 4-chamber view. Left atrium. The right atrium should be over here, but instead I have jump rope going on. Can everyone see this right here? So this is actually a 5-chamber view because here's my aortic valve. So this is the aorta. That's not normal. This is a big dissection flap, and we've caught this massive aortic dissection.
And there's no right atrium in this, right?
Correct. The right atrium in a 5-chamber view, you will see a hint of the right atrium, and you get a little hint over here of it, right there. But this aorta, the echo tech here did a great job of pulling this into the plane of view. I just like to gaze at this. This is an amazing picture. Whew! That's something that needs an urgent surgical consultation. Okay, so our treatment, as you know, you really want to lower the tension on the wall. I gave you my beautiful paper illustration. So this one, you don't mess around. You got to get that blood pressure and that heart rate down. Now, if you are concerned about cerebral perfusion, you're just going to have to see what happens when you lower, because if you don't lower the blood pressure and the heart rate, then the wall tension stays high. So labetalol is your IV medication of choice because it gives you alpha, it gives you beta, it's going to lower that tension, it's going to lower your heart rate and your blood pressure together. You can also use nitroprusside. Now, you really want to get them down to a systolic of 100 to 120, get that heart rate down low. So you want them in as best a shape as possible. You should try to avoid vasodilators if you can. This is the classic teaching. So hydralazine and nitroglycerin are not good medications for this. Sometimes you're forced because you're stuck and you're choosing between, I really need to lower the wall tension and I don't want to give them vasodilators because I do want to keep good preload going, but sometimes you're gonna be stuck and have to use a little bit of hydralazine. But labetalol followed by nitroprusside would be the 2 medications of choice for this. Type B are managed medically. The only things that make us think about surgery are persistent pain, because that suggests that it has ongoing dissection, or if you compromise some end organ, particularly your renals, and then the extent of the dissection. But you'll see Marfan's patients who live and they're dissected from stem to stern, and they just live that way because actually repairing it would be more dangerous than leaving it be. Type A, these really need surgical management. So if you get someone with a type A, not only do you need to involve your attending, you also need to get the surgeons to be consulted immediately because of all the serious complications we talked about. We didn't mention tamponade, so you can actually dissect into the pericardial sac and end up in tamponade as a result as well. Okay, great. Questions about aortic dissection, and then we'll use the last 5 minutes for a few special circumstances. Okay, so pregnancy, warning, don't try this at home. I don't take care of pregnant people without OBs, and I don't like being called to the 3rd floor, but sometimes you are. So preeclampsia, just to remind you, this has to be new hypertension plus proteinuria or hypertension plus end organ damage. This can actually be sometimes a difficult diagnosis to make. Eclampsia is if you add seizures into the mix. So in pregnant women, you've got to check their urine for the protein, CBC, CMP, and then do a fetal evaluation. Women are treated a little bit differently than our patients. They're all volume depleted if they come in with preeclampsia. So you give them volume, which normally we think about avoiding saline in hypertensive crisis, right? Because you don't want to give them that salt load. But here they're volume depleted. And then IV magnesium is going to be one of the main treatments of choice, both because it prevents against seizures and it also lowers the blood pressure. And then you can use labetalol or nicardipine in pregnancy. That's all I'm going to say. Don't ask me any more questions about pregnant women. I don't like it. Okay, so here's an MRI showing you PRESS, which we mentioned earlier, posterior reversible encephalopathy syndrome. So here's headache, altered mental status, visual change, seizure. This is vasogenic edema from the loss of cerebral autoregulation in hypertensive crisis. And you just treat it like hypertensive crisis, but keep this on your differential. Okay, now a word from our sponsors about stroke. There are hypertensive strokes, and then there are strokes that also have hypertension, right? And what you do for these, well, let me just tell you that the data is out. We don't know if hypertension is going to be harmful because that might exacerbate edema and hemorrhage, or if maybe it's helpful because you get distal perfusion beyond in that ischemic tissue. So there's all kinds of theories and hypotheses. The studies that have been attempted in this are actually pretty much a wash with mixed results. So the recommendations currently from the Stroke Society is Just don't actively lower the blood pressure in the first 24 hours unless, and they give you a number, greater than 220/120 or some other complicating condition. And we see this all the time, right? Heart failure, stroke, hypertension. So then maybe, and they're in pulmonary edema. So if you have some other condition which you need to treat, then you can lower the blood pressure more aggressively, but they say leave it alone for the first 24 hours. And then the only other caveat is if they're going to give TPA, you obviously don't want to give a thrombolytic if they have very high blood pressure for the concern of bleeding in the brain. So they set a cutoff of 185 systolic in order to give TPA, so they'll give a squirt of labetalol, then give the TPA, and then do their whole dance. But I just want you to know that this idea about not lowering the blood pressure, even though that's dogma and people teach it to you, the studies actually we don't have strong evidence support one way or the other. Okay, so we already had scleroderma renal crisis come up. I'm going to tell you about this. It's rare, but if you end up practicing at a place where you have a lot of rheumatologic patients, you're going to need to know about it. So people with scleroderma, they end up getting this intimal hypertrophy and proliferation inside the renal arterioles, and that gives you these onion skin lesions. This essentially acts like renal artery stenosis, but they can end up with abrupt acute kidney injury and hypertension, although not all of them are hypertensive. That's not fair. This is also a microangiopathic process, so they can end up looking a little bit like TTP-HUS. So you have to differentiate and try to make that diagnosis. But if you do make this diagnosis, you treat them with ACE inhibitors. ARBs are a little bit less on the list, but ACE inhibitors to control the blood pressure and carefully monitor the creatinine. So this, to answer your question, Michael, is the one situation in which even if they have some acute kidney injury, I'd give them the ACE inhibitor because the pathophysiology matches. This is pretty rare. I've seen it once or twice, but just keep it on your radar screen. Pheochromocytoma, we always bring it up, and it's an important thing to think about. I have seen this once so far. So the catecholamine secreting adrenal medullary tumor. By the way, why are they called the adrenals? Because they're on top of the renals. So it's just, right, they sit right on top of the kidneys. That's why it's called adrenal. So this is an MRI showing you a really massive adrenal tumor on top of that kidney. So the triad classically, right, sweating, headache, tachycardia, flushing, and we think about episodic hypertension, although they can also have chronic hypertension. This you got to diagnose with a 24-hour urine collection. So if this is on your list of a possible secondary cause, then I actually start that urine collection in the hospital because it's really hard to do a 24-hour urine collection outside of the hospital. You've got to get imaging, and then your TCAs and SSRIs actually interfere with this assay in the urine. So you want to discontinue those before you collect the urine. So treatment for pheochromocytoma, there's sort of two instances in which you might have to treat this. The first is if you find it, they're going to need to get it taken out. And there's a big concern about crashing during surgery because of all the alpha agonism that's going on. So preoperatively, if you've made this diagnosis, they get an alpha blocker for 10 to 14 days first, and that's phenoxybenzamine. So you do that and adequately treat the blood pressure. Then, about 2 to 3 days before surgery, you add in the beta blocker. But that's important because if you give the beta blocker first, unopposed alpha, we talk about that with cocaine all of the time, but you have to worry about that with pheo. You can also sometimes get hypertensive crisis with pheo. So I've seen this once, a young woman who came in with hypertensive crisis, pulmonary edema, had a respiratory failure, intubated in the NICU, and crashed and burned. And she ended up needing to go on ECMO, actually. And then she had bilateral, massive 14-centimeter adrenal tumors. It was crazy. She had to go from ECMO to bypass surgery. Oh my gosh, it was crazy. But she recovered. So in hypertensive crisis here, nitroprusside is going to be your friend. So nitroprusside drip is good. You can consider this short-acting non-selective alpha blocker. I've never used it. I get concerned about using things I've never used before. So I'd probably go with nipride unless there was some other reason. And then I would have some conversations with the pharmacist before I pulled out this phentolamine. So that's really all that I know about pheo. Don't ask me any questions. It's pretty rare. Okay. And then a word from our sponsors about cocaine. We always talk about this. You guys are very well versed in treating cocaine. You're always concerned about unopposed alpha, giving a beta blocker, and that's going to cause some problem. Let me tell you something. So there's a guy named Richard Lang who was one of my attendings in residency. And when he was a fellow, they did this crazy study in the 80s, which I don't know how you could get this passed now. They took people, and let's see, they took people who used cocaine, No, they didn't use cocaine. They just took people to the cath lab and they squirted cocaine down their coronary arteries. And then they gave them beta blockers and see what happens. So this is like a direct, and they were literally measuring the diameter of the artery to see what happened in this theoretical, like, here's some cocaine. Oh no, it wasn't, they didn't squirt the cocaine down the arteries. I think they like just administered cocaine IV. It's amazing, right? There were like 14 patients. So it turns out that the unopposed beta blocker really didn't harm those patients very much. So kind of the teaching is that if you give them labetalol, it will lower the MAP, but it won't alleviate the coronary vasoconstriction, and that if you give nitroglycerin, that will alleviate the coronary vasoconstriction, and the calcium channel blocker will alleviate the hypertension, but won't necessarily touch the tachycardia. So the bottom line is just do what works for these patients. I have no problem with a non-selective beta blocker in the setting of cocaine, so carvedilol, labetalol, I'm perfectly fine with those. But nitroglycerin also is usually where I start if they're having chest pain, and then see where we go. Remember, the cocaine metabolites take several days to wear out of the system. I've also seen someone go on ECMO because of such severe cocaine-induced coronary vasospasm that they would just stop pumping their heart every time that the metabolites cause the cocaine vasoconstriction. Also a bad day at the office for that guy. Okay. Well, I just told you to use nitro if the coronaries are. It can cause profound hypotension, so you just have to be careful, but it depends upon the situation. Okay, so lastly, I'm going to do a few cases just to whet your appetite, and then we'll be done. So 26-year-old guy with hypertension comes in with a blood pressure of 220 over 110 and chest pain. Chest pain is substernal and it's radiating through to the back. What do you want to do? If you had this patient with me, don't say anything, because this is a real case. Tearing chest pain. First diagnosis first. He's having chest pain and blood pressure. Okay, you can give him some labetalol in the meantime.
First thing is cocaine.
Okay, so get a drug screen. Drug screen is cannabinoids only, but he doesn't use cocaine. Vehemently denies. Chest X-ray, normal mediastinum on chest X-ray. He's having tearing chest pain. You gotta look, right? So CTA was equivocal, so he ends up getting a TE, that's negative. EF is normal wall motion. Okay, so now you choose a treatment choice. So I heard labetalol, perfectly reasonable. We know his EF now also, so we feel pretty good about that. Here's what his labs were. He had a little bit of troponin, low potassium, and elevated creatinine. Does that make you think of anything? Yeah, this always makes me worry about hyperaldosteronism, which he ended up not having, but it's really important to know what the K is when they first come in, because I would definitely be thinking about hyperaldosteronism in this guy. And then we said that there were cannabinoids. Okay, so we put him on, let's say we did labetalol. I don't actually remember what we gave him. Let's say it was labetalol. Good. Okay, and then all of a sudden, the next morning during rounds, he's like, oh, I can't really see, and he's acting a little funny. So now what do you do? Okay, so CT head's got to be there for sure. And what else? And yeah, so look in the eyes. We're not good at that, so we couldn't see anything. How about a visual test, right? And this dude literally has like hand waving alone in one of his eyes. So he has definite unequal visual changes. So we also called ophthalmology. So his CTA of the head and neck was negative, but there was motion artifact. And when we called ophtho, he had papilledema. But they said this is not enough papilledema to cause this degree of visual loss. Right. So we're worried about press, so we do an MRI. And they tell me all these things that I don't know what they mean, but they tell me it's not press because there's no edema. So now we're like, well, gosh, what else is going on? So we decided to do an LP because we need to make sure that we don't have some other cause of his altered mental status and his visual changes going on. And neurology tells me it's safe to do even though his blood pressure is sky high. I'm like, are you sure? They said, yes, we promise. And as I forget who here was doing this LP. Who was, I forget, oh yeah. And as we're doing the LP, he's like, oh, I can see. And we're like, what? Right, so we're worried about crypto, right? Because he has this high opening pressure. But it turns out that he just had, oh yeah, classic. We don't actually know why he had such high blood pressure, but his vision was gone because of elevated intracranial pressure. And by alleviating that elevated intracranial pressure, he ends up getting his sight back. So this was a cool day, because like I've raised the dead before, but I've never caused the blind to see. So this was a pretty good day at the office for me. Okay, one more and then I'm going to be done just because this is important. A 55-year-old guy released from jail 5 days prior, headache, some vague chest discomfort, blood pressure 190 over 110. What's your first question for this guy?
Okay.
Okay, no cocaine. What's your second question? So he got released from jail 5 days ago.
Do you take meds?
Do you take meds? Yes, I do. What do you take? I don't know. What's your guess?
Clonidine.
He didn't take it, and then he was on clonidine, right? Because what do they treat you with in jail? They treat you with clonidine. So for this dude, I just gave him some clonidine. Have a nice day, right? Okay, great. I'm going to stop there. I have more, but it's time to go. Thank you guys very much for your attention.